very high infection rates. Where did this data come from? Well, it turns out this data was coming from antenatal clinics. It was data of basically pregnant women. So you can see already a couple reasons why that data may not be the most representative data. First, I already showed you the better data, and I'll tell you where it comes from, showing that women's infection rates are much higher than men. So if we're looking at the overall population average, just looking at women overstates the problem to the extent men have a lower infection rate. That's one issue. Second, if you're looking at women in antenatal clinics, like by definition, they're sexually active, they're pregnant, they're having unprotected sex. So there's not sexually active adult women, there's sexually active adult women who are having protected sex, et cetera. They're not really the ones in the clinics. So that's another biased sample, basically. So when these numbers came out, I think everybody kind of knew that they were too high, that it couldn't really be this high, but no one had better data. So shortly afterwards, and this effort continues, but one of the first of these surveys was in Kenya, demographic and health surveys came out that tried to get a representative sample of the adult population to try to get better numbers. The first one in Kenya was in 2003. They got about 3/4 of adults. They basically went around, tried to sample adults, with every adult having equal probability of being sampled. They would walk home to home and count off every fourth or fifth home and survey someone. 3/4 agreed to be tested. About a quarter refused to be tested. So let's just keep that in mind and try to think about who those people might be. In the Thornton piece, she has some evidence about those folks, or related folks. So 3/4 agreed to be tested. And numbers came out about infection rates. Which numbers would you tend to believe more? The antenatal numbers or these numbers? What are some of the limitations of these numbers here? Yeah. Yeah, so if the people who refuse are the ones who are very infected, or very likely to be infected, and they're maybe afraid that the information will get out, someone will find out, so they don't want to get this information in anybody's hands, then maybe this number would understate the true infection rate, actually. What else? What other concerns might you have? Or why might that top number just be a better number to think about in any case? Yeah. For sure. So within the sort of AIDS advocacy community, remember, it was right around this time that people were pushing for ARVs to be made available, to be funded, et cetera. There was actually a lot of backlash among AIDS advocates when these numbers started coming out. So I'm going to show you these numbers are a lot lower than 15%. Among people saying, wait a minute, we finally have momentum to do something. Tens of millions of people are going to die. Screw the data for a couple years. Let's just get stuff funded. Like, these numbers are a distraction for what is a huge crisis, and they're going to kind of, mobilize people who don't want to do anything about the crisis to begin with. Now, as researchers, we don't like those arguments. We like to get the best data we can and make the most informed judgments we can. But you might say, well, hey, 30 million people are going to die. Maybe it's okay. I mean, that was certainly the perspective of a lot of the advocacy groups at the time. What other rationale might you have for focusing on that top number? It comes to a comment that I think was made earlier. That top number may be the relevant number when we think of transmission to kids, which is an issue that was raised before. So if we really care about that issue, that 15% number is a pretty relevant number. 15% of kids were at risk, actually, of infection. So anyway, you might like one number or another. The other thing is if you're thinking about the risk of infection, if you are sexually active, maybe that's the relevant number too, because that's a pool of people, of young, sexually active people. So the 15% number has its sort of value, and it's shedding light on a certain population, but it's still not like the national number. So what does our best guess of the national number look like? Well, in those early surveys, the best guess was about 6.7%. In the more recent rounds, with better coverage and a higher fraction of people agreeing to be tested, it's more like 6%. So 15% to 6%, that's a big reduction in infection prevalence. And this question comes up, which is closest to the truth? And I think we've discussed some of the issues. Probably, it's not certain. Probably almost certainly the first number overstates infection, but probably the second number understates infection. The truth is probably somewhere in between. And there's just a question about, where exactly it lies. Yeah. Over time, I understand, I don't have the exact data here. My understanding is more people have been willing to participate. There's a number of reasons why. Now you can get ARVs. In 2003, that was just like when they were starting to become available. So there's a sense that, like, A, finding out I'm positive isn't the end of the world, because I can do something about it. And B, in cases where it's discussed more, maybe stigma is a little bit less severe because people are living with the disease, people may be less reluctant to do so. So my understanding is over time, people are more and more willing to participate. And that's good because we're going to get closer to the truth. Like if we can get that number instead of 73%, get it up to 95%, then we have a pretty good sense of the population. Yeah. Yeah. Sorry? Oh, I said, well, in Thornton's article we're going to get to, we're going to have some data on that, but what I'm saying now is a little bit speculative. Okay. So this is the data from the Kenya survey, and you can see, this is from the 2003 survey, and you can see it's broken down by gender, women are in the top line, men in the bottom, and by age. So let me just pause for a second. Well, let me highlight one pattern to start with. The first pattern I've already said is, you can see in Kenya at this time point, women have a much higher infection rate than men. So that kind of, Africa-wide pattern holds in Kenya too. Almost twice the infection rate as men. But what other patterns do you guys see other than that one that we've already discussed? Yeah, Radhika. Yeah. And in general, it falls a lot at that point. Do you have any speculation on either the fall when people get to be older or the gender difference there? Yeah, but if they were infected earlier, they would still be infected. So why is it falling over here? Yeah. So the death is going to be a key issue here. So one of the reasons this could drop off over time in this era, part of the reason I'm focusing on 2003 is because before the ARVs were available, basically. So at this point, if you had been infected 10 or 15 years earlier, you probably didn't live to 49. So the drop off over time could be because of mortality, and maybe there's some difference in mortality by gender, or that's one possibility. But the differential mortality is part of it. What is another explanation for the drop in that older age group? Exactly. So you've raised an interesting point. So Radhika pointed out, look, it sort of drops for women here. You see that the younger women are actually infected earlier. So again, maybe they're dying off sooner, and so those older age groups, you just don't see that many infected women left. So that's a very interesting pattern that comes out of this kind of age differentiation. Okay, another possibility has to do with when the epidemic started. So the epidemic starts really in the 80s. And this is a 2003 survey. So if these folks in the 40s were at their most sexually active 20 years earlier, there was just less HIV infection then. So some of this could really be what we would call a cohort effect, that there just wasn't that much HIV early on. But for these guys, it kind of rises. What we're seeing here in reverse is like the spread of the epidemic, basically, because most people are most sexually active in their late teens into their 20s, and then the degree of sexual activity falls off with marriage, and people have more stable partnerships, et cetera. Okay, what other patterns do you guys see here? Those are some good ones. Yeah, right. And so it's interesting. Part of that could be differential sexual behavior after that point, or it could be this mortality issue. Just from this plot alone, we can't distinguish it, but it is pretty striking, right? That for men, it just keeps rising. Let me emphasize a couple things. We already discussed this issue. You can see I've highlighted this age group because a lot of the women in the antenatal clinics are really going to be in their 20s. So you can see, for the 25 to 29, the infection is like 13% here. It's not too far away from our 15% number we saw before. So there's some kind of logic to that number. This young age group is very interesting. If you look at late teens, the infection rates among males is like almost 0. And the infection rates among females are pretty high, 3%, 3.5%. There's this huge age difference in that early range. And there's actually some research on this. Pascaline Dupas, who's at Stanford, has some work on this. Women's sexual initiation, the start of regular sexual intercourse, is much earlier in Kenya than it is for men. So very few of these guys are sexually active at this age, but a lot of the women are sexually active. A lot of the young women are sexually active, very often with older men. And so people call these kinds of relationships like sugar daddy relationships. That's the term that's used in Kenya. So that is part of the reason why you see this big increase early on. Now, Pascaline Dupas had a study where she provided information. So it's a, in some of the clicker questions, you guys can see we all have some misconceptions about the epidemic. It turns out it isn't very well known what this pattern looks like. So, if these girls are having sex at this young age with men in this age range, or this age range, their infection rate for the men is like 7%. If instead they have sex with men in their own age range, their chance of infection is very low. So she went to schools. It was an RCT. It was a randomized control trial. She went to schools and had sort of supplemental sex education classes and showed people basically plots like this and said 15 to 19-year-old males have an infection rate almost 0. 30-year-old males have an infection rate of 7%. You choose, basically. That's kind of what she did. And she found that going forward, there were changes, very large changes in self-reported sexual behavior among these girls. They weren't having less sex, but they were having younger partners. And there were a lot of very happy 15 to 19-year-old men as well. She asked them their life satisfaction. Yeah, so that's an example of a research study. But it gives you a sense that very simple pieces of information that everybody can understand can actually change your life. Like, this data isn't that complicated, but it isn't like people are sitting around analyzing the data in their daily lives. So if you can boil it down for them to something simple, they can start making more informed choices. Okay, yeah. There's a lot of questions about that. There's another set. So this study by Dupas was in Kenya. There's another set of studies by co-authors Baird et al. It's the same Sarah Baird that I've worked with on some of my stuff. I think it's 2011 or 2012. She has a paper in the Quarterly Journal of Economics, QJE, on sexual behavior and school participation among these like late adolescent or early adult women in Malawi. So they have a different setting. And they find that basically when a lot of these adolescent girls drop out of school, they almost immediately initiate regular relationships with older men. That's very typical. And the reason why there's this sugar daddy kind of term is the notion these older men buy these girls gifts or somehow support them to some extent when they're out of school and just figuring out what they're going to do with their life, what they're going to do with work, if they're going to marry, etc. And so there's this kind of very vulnerable time in the late teen years for girls or teen years for girls who have dropped out of school or young women who have dropped out of school. The Baird et al. Study shows that for these girls who drop out of school, if you give them a moderate-sized cash transfer, just give them some guaranteed income for the next year or two, they're much less likely to have sexual relationships with older men. They're less likely to get pregnant, etc. They're less likely to actually get sexually transmitted infections. They have data on that. So there's something about the vulnerability of these young women or adolescent girls when they drop out of school that a cash transfer from an NGO can help with, so they don't sort of fall into these very dangerous relationships. In the context of the HIV/AIDS epidemic, these sugar daddy relationships are extremely dangerous. Okay, another clicker question. Based on this data I've just been showing you, are infection rates higher or lower among wealthier households? Are they higher among wealthier households? Are they lower among wealthier households? Roughly equal? And then the usual D&E. Who's most likely to be infected? Okay, I know what you're thinking. I've got it. We're going to tally it up. Maybe let's wait until after the clicker question. Yeah. Okay, so here, the kind of consensus among you all is that infection is lower among wealthier households. Infection rates are much higher among wealthier households in this data. And as we saw before, across regions, it's the wealthier African countries in southern Africa that are more likely to be infected. So just another kind of idea or misconception around the epidemic. Let me show you a pattern, and we'll talk about that because that's one of the explanations that comes up. So percent HIV positive, and this is again from that same Kenyan data among adults. And let me just move this thing over. And what you can see here is urban folks have much higher infection than rural folks, about twice as high. Again, urban areas are much richer than rural areas. It turns out in the survey data, people in urban areas also have more partners, more sexual partners. It also turns out, and this is true in most societies where there's data, wealthier people on average have more partners than poor people in most countries. So, in the case of commercial sex, access to commercial sex workers, that could be part of it. But even independent of commercial sex workers, wealthier people on average tend to have more partners. There's a lot of different possibilities for why that is. To the extent that wealthier and more educated people marry later, they may have a longer period of time where they're unmarried and sort of not in a stable relationship. And during that period of time, they may have more partners. That's one of the reasons why you may see that kind of relationship. So urban people have more partners. In terms of education, the lowest infection rate is among the least educated, and then it kind of rises up to completing primary and then maybe levels off or drops a little bit. But certainly the least educated have the lowest infection rate. You can see that in the red box. And then at the bottom, there's what's called a wealth quintile. Basically, they collected data on the assets that people own: cars, bicycles, radios, cattle, and they came up with an index of wealth. And then they divide households into quintiles. The lowest quintile is the poorest 20%. Richest quintile is the richest 20% in terms of ownership of assets and wealth. And you can see that the infection rate among the top quintile is more than twice, almost 3 times as much as the bottom quintile. So the wealthier folks are much more infected than the poorest folks in this setting. And then, of course, the question is why. So we came up with this idea, well, wealthier people are having more partners. Can people think of other reasons or explanations? Right? That could be the case, and we'll come to that when we talk about the model of behavior. But consider this survey from early 2003 as basically pre-ARVs. It was surprising how quickly the antiretrovirals rolled out, having been there at the time. So that's going to be an explanation for today, but less of an explanation for 10 years ago. Yeah. More what, sorry? Mm-hmm. Yeah, so mobility is something that's talked about a lot in this literature. People who are working away from home are much more likely to have more partners. So in the case of Southern Africa, in other words, all those Southern African countries with very high infection rates, one of the sort of stylized facts of the spread of the epidemic was a lot of male workers who were far from home working in the mines and not living with their families had lots of basically access and opportunity and also good salaries to basically have intercourse with commercial sex workers. So, mobility, being away from home, some of the groups with the highest infection rates in the early spread of the epidemic were truckers, people involved in long distance trade, people who were just away from home, basically. So mobility is part of the story. What are some of the other, a few other hands? Do you have your hand up? Yeah. That's right. So if we're having more partners, or if there's a commercial sex sector where the commercial sex workers have a high infection rate, those commercial sex sectors are going to be more developed in urban areas than in isolated rural areas. And that could be like a vector of infection, basically. Which I think is what you're getting at, Martin?
Also, like, you can see that people are more educated, have higher infection rates, and people who, have less therapy, more educated.
Yeah, I mean, it's a bit surprising because, I think your guys' intuition, everybody's intuition is, you're educated, you're wealthy, you're going to do the right thing for your health, but not in this case. Not in this case. It very much goes in the opposite direction. But maybe I misunderstood your point.
Also, is there, you said internationally big thing,
yeah. Much less. The view here is there's very little intravenous drug user transmission and relatively little, it wasn't like it was a big concentration only in, say, the gay male community here. This was a generalized epidemic mainly spread by heterosexual intercourse. Yeah. Yeah, if you're wealthier, you can afford to go to the bar and buy some beers and sort of just partake in a sort of social life that poor people can't access as easily. That's right, yeah. They're in the population, just in the population. They're not singled out in this data. There are other surveys that focus on them, but there certainly would be some in this data, but they're not broken out here. But most of them are going to be urban. A lot of them are going to be female. Oh, in terms of earnings? There's some pretty interesting research that was done by a graduate student here. There was a guy who was one of the student of mine who finished maybe 6 or 7 years ago. His name is Ethan Ye. Damn you, pen. Sorry. Okay. I'm going to get it right this time, I promise. Okay. So Ethan is one of our students, and he wrote a paper with John Robinson, or a couple papers with John Robinson, who's at UC Santa Cruz. Ethan left academics. He's at Twitter now, so he's living large. They surveyed commercial sex workers, women in Busia, Kenya. Busia is on the border. It's like a big trade town. It's a big trucking route. So there's a lot of bars that serve as basically meeting places in the commercial sex sector. And they surveyed hundreds of women in town who were commercial sex workers, and they're pretty well off. They earn, relative to the typical urban dweller in Busia, they're pretty well off. They're definitely above the median in terms of earnings. Of course, they're facing terrible risks, and their rate of HIV infection is quite high, much higher than 5%. So, but there is actually some data on them. They're pretty well off. They're pretty educated. So even the commercial sex workers have, the vast majority of them have finished primary school, which puts them above the median. They're earning a decent wage. It isn't like the poorest of the poor going into that sector, at least in their data. So I think a lot of our preconceptions about the sector are a little different than the reality in at least some of the African settings. Yeah. I think there's a general view everywhere that that's the case, and it's certainly the conventional wisdom in sub-Saharan Africa that rural areas are more conservative than urban areas. There's just more traditional authorities and traditional structures and sort of more eyes on you in some ways in a village than in Nairobi, which is a huge city with many millions of people. And a lot of people go to Nairobi to kind of start anew, and that's true of cities everywhere. So I think in that sense, sexual norms will differ in those areas. Even in, say, Busia is a town, but it's in a predominantly rural area. Even in that town, there's a very big commercial sex sector. And we tried to work out the demographics, so these guys tried to work out the demographics, and it was kind of surprising, but the fraction of young women in their 20s who were commercial sex workers that they identified, that openly identified in surveys as commercial sex workers, was like a few percent of women at age range. It wasn't like a tiny fraction of 1%. It was like, I forget, 3 or 4% or something like that. So it was pretty widespread, even in a kind of country town. Okay, so we've talked about the extent of the problem. Part of the reason I had the clicker questions was just to kind of make the case that we don't necessarily know about the epidemic as much as we think we do. What I want to do next is answer these next 2 questions. First, what is the impact on the economy? There's a lot of different ways HIV/AIDS could affect the economy. We're only going to talk about some of them in detail, and then we're going to talk about the behavioral issues around the spread of the disease. So that's what we're going to focus on next. Unless there's any questions on patterns and all the kind of demographics I was showing you right now. Any last thoughts or questions, Martin?
Since, like, a lot of population of Africa is underage, why do you tell me that our population is different for kids?
You're saying why among the youngest kids? Okay, so I should have come back to that. So if you were born HIV positive in the era before there were antiretrovirals, the likelihood that you lived to adolescence was low. So a lot of the kids that were born HIV positive in the 80s and 90s did not live to adulthood. So it was a terrible tragedy. These kids died young. Now, once they figured out that if you gave the mom, even if she was infected, you gave her antiretrovirals, you would basically reduce the viral load enough that she was much less likely to transmit to her kids. At least for people with access to clinics, the problem of HIV-infected babies fell a lot. So the issue changed with sort of those policies, those health policies. And even now, if you are infected and you are a kid, there are antiretrovirals. So I'm kind of lumping them together because it's one of those success stories where mother-to-child transmission, reducing mother-to-child transmission was one of the early success stories of antiretrovirals. And it was recognized as such. Yeah. Yeah, so there's some good studies on this from that same site. I remember I mentioned in 2003 we went to one of the first